Right, so for those of you who don't know me, I think most people know me now. My name is Jimmy Johnston, and so this is a topic that I use in clinic, and it often played on my mind. So, should I start this patient on androgen deprivation therapy now, or should we wait? And so it's something that I wanted to look further into. That was just a little bit intimidating when I realised that certain members of this department have written and spoken extensively on this topic, including certain members sitting today. So start with the disclosures slide. So I looked up disclosure, and it's the act of making new or secret information. And so this year, being in Vancouver with a small family and living in a fancy address in Kitsilano, I've had to learn to save money. And so up on the top there is drying my tea bags, and it's my Glad wrap that I've washed, and that's drying too. I've got my $2.15 goes a long way when you can go Starbucks about 5 times a day, and I nearly always pay for my bus fare. So I'm going to talk a little bit about the history of androgen deprivation therapy or castration. I'm going to talk about its role in watchful waiting, node-positive patients, recurrence, and intermittent suppression. There are some topics that won't be covered in this just because it's such a ginormous field. So regarding history, this is castration and the removal of genitalia has been centuries, and this is ancient Greek mythology, where Uranus, no laughing Ed, is castrated by his son Cronus for imprisoning his brothers. Medieval battles, they took their prisoners and they cut off their bits as well. And William Wallace, I think not Mel Gibson, had his parts taken off as well when he was drawn and quartered. In Chinese cultures, for about 3,000 years, eunuchs were part of the employment of the government, and they were to look after the harem. And they often had quite a lot of influence because they would be so close to the leaders. And for that reason, they were somewhat polarizing people, and that people, I guess they looked up to them, but they saw them as a bit sneaky. In more recent times, you may have seen this movie about Alan Turing, the father of computers. He was a homosexual, and he was committed of that act in 1952. And rather than going to prison, he accepted castration. From a scientific side of things, and around about 1840, this guy John Hunter noted that the prostate gland, Cowper's gland, and the glands, along with the urethra in the perfect male, he's talking about cows here, are large and pulpy and secreting a considerable quantity of slimy mucus that is salty to the taste. And the castrated bull was small, flabby, tough, and ligamentous. And then more recently, Charles Huggins, a scientist from Chicago, born in Nova Scotia, here in Canada, had 21 men with locally advanced or metastatic cancer, and they underwent castration, and he noticed a marked improvement in all but 3 of them. Importantly, he noticed that the 3 that didn't do so well had small testicles at the time of their castration, and he received a Nobel Prize for that. A second Nobel Prize was given to Andrew Skelly for his identification of LHRH, which has led to the modern-day androgen deprivation therapy, and he received in 1977. More locally, you can find suspicious levels of androgen around the place. So, of course, this is the hypothalamus pituitary gonadal axis, where LHRH, a 10 amino acid, is released and causes the secretion of testosterone. Aromatization in the peripheries converts that to estrogen, which then can have a negative feedback. And so they're formed from cholesterol, and it can be mostly in the testicle. Testosterone is the major androgen, of course. It's converted to dihydrotestosterone by 5-alpha reductase, You can get androgens from the adrenal gland. And so androgens pass into the cell, they're converted to DHT with 5-alpha reductase. They interact with the androgen receptor, which is a ligand-inducible transcription factor. So what it does is it goes then interacts, conformational change interacts with the genetic material to have its. And so castration or androgen deprivation therapy globally either inhibits secretion or inhibits the action. And within inhibiting secretion, it can be medical or surgical. So this debate has been around for a long time, but what's changed in prostate cancer? Well, PSA came about in early 1990s, which has brought about an earlier stage of diagnosis, but also an earlier recognition of recurrence in patients who may have a poor prognosis. We can now use medicine compared to surgery to castrate, which has removed some of the stigma behind castration. People are living longer, and people with advanced disease are living longer. So these side effects can become more important. So we have to factor that in. So I'm going to try something called Poll Everywhere. So if you've got a device in front of you, if you go to pollev.com, or there's you can text something as well. We'll see how this goes. I think that you could probably do it on your phone. When I've used this, I use my computer. So we're going to move on. There'll be some instructions. These will be repeated later on if you miss it. Does it work? Maybe not yet. So this first patient is an 85-year-old man. He's got prostate cancer. 3 + 4 = 7. 5 out of 12 cause. T3 clinically. PSA diagnosis is 11. So see the patient in your office in 3 years' time. What PSA would prompt you then to initiate androgen deprivation therapy? So this guy's on watchful waiting. So it should work. How do you get it live? We might just have to do a straw poll. Yeah. Okay, sorry, it's not coming live. We'll just do it by straw poll, sorry. Okay, so in 3 years' time, what PSA would prompt you to start androgen deprivation therapy? So 3 years' time from PSA 11, would anyone go for 22? No metastases. So 43, 55, 63, anyone? Well, only, and yeah, for Dr. So only 2 voters, 3 voters, UBB. Yeah. So I guess what I'm trying to show is that there's variation. And I'm sorry that didn't work. It's a real shame. What's that? Yeah, so we're going to come to that. So watchful waiting is an appropriate approach for men with localized disease who've got limited life expectancy. And generally it's a conservative approach until they progress biochemically, locally, or systemically. And so, you know, prostate cancer, we know that in many patients it's not always a fatal disease in studies such as this. And in 2008, Studer and others in the EAU RTC trial published their work with non-metastatic prostate cancer. And these patients were between 1990 and 1999, and they were newly, and men under the age of 80 who refused or were unsuitable to undergo radical therapies due to comorbidities, the disease itself. And 468 underwent immediate androgen deprivation therapy, and 471 had deferred androgen deprivation. So 8 years follow-up. They found that a PSA over 50 compared to 8, the diagnosis had a 3.5-fold higher chance of dying from prostate cancer in both the patients who received androgen deprivation therapy straight up or those who had it deferred. The 7-year cumulative incidence of death was 9.2% versus 7.9%. And they concluded that although survival may not be significantly better, they would benefit from immediate androgen deprivation therapy to prevent complications. Then they also looked at doubling time for patients with PSAs between 8 and 50. They looked at the doubling time. What they found was that patients with a doubling time of less than 12 months compared to over 12 months had a 7.5-fold higher risk of dying from the prostate cancer. So based on that, PSA over 50 or a doubling time of less than 12 months between 8 and 50. So 6 years later, in 2014, they published again with now 12 years follow-up. And what they found was that patients who had the immediate androgen deprivation therapy had reduced objective progression at 10 years. They, however, had a similar time to castrate resistance, and it's if the red line here is patients who had deferred arm, so they did not get androgen deprivation straight away, and this arm is the ones who had it straight away and they were progressing, that automatically makes them castrate-resistant prostate cancer. And so when the patients switched from the deferred arm to the androgen deprivation therapy arm, they found that the rates of castrate resistance was the same. They found all-cause mortality, non-prostate cancer mortality, and prostate cancer mortality similar between the arms, but at the 10-year mark, the all-cause mortality was slightly higher for the patients who had deferred arm. Not sure why that. In this trial, it's important to realize that a lot of the patients in the deferred arm didn't actually receive androgen deprivation therapy. 30% of them died without ever having. Those who had deferred androgen deprivation therapies, there were less patients who were treated. The average time on androgen deprivation therapy was less as well. So less time with the side effects, less costs. So with regards to metastatic disease, there are some studies from the 1960s and 1970s from the Veterans Administration Cooperative Urological Research Group. There were two main trials from this, and in the second one, they looked at placebo versus an estrogen. But those patients who were placed on placebo were never actually given any treatment when they progressed. So it's really immediate androgen versus none. And you can see from this graph that the patients who had placebo or a 0.2 milligram dose did significantly worse in terms of progression. What is also interesting is that the patients who had the 5 milligram dose of estrogen had significantly worse cardiovascular mortality, and so that dose was actually stopped. And another aspect of this trial, they assigned people to either placebo or castration orchiectomy, and they found no significant difference between the two groups in survival. They were allowed to switch from active to active therapy when they had symptoms. And overall, this is some time ago now. The recommendation is that they should not be treated until their symptoms require it. More recently, the Medical Research Council, 1997, still quite old, reduced morbidity with reduced pathological fractures called compression, ureteric obstruction, vascular metastases. There was improved survival for M0 patients, but not. So for watchful waiting, this is sort of my own thoughts more than anything. I think it's good for localized disease with a life expectancy less than 10. In symptomatic metastatic disease, obviously give androgen deprivation therapy. In asymptomatic metastatic disease, probably give androgen deprivation therapy And in a non-metastatic setting, consider it when the PSA is over 50, the doubling time is less than 12 months. So that gets so I'm not, but okay. So so we're going to move on now to post radical prostatectomy recurrence. So this is the next one here. So 75-year-old man who has a radical prostatectomy. As pathological features were T3B 4+4 equals 8, PSA 18 pre-op, margins and nodes clear, and his post-op PSA is 0.01. So in 2 years' time, what PSA would prompt you to start androgen deprivation therapy? So would anyone have started it already? Nodes are negative. What's the what? Okay, so quite a lot higher than this, obviously. Yeah, so that's an important point. So this is, obviously can't capture everything. The whole point about this is that every patient, so you can't, this is really quite false. So would anyone give it at 0.2, 0.5? Okay. So biochemical recurrence post-radical prostatectomy is defined as 0.2 nanograms per ml or greater with a second confirmatory. And that's adopted by AUA and guidelines. And it's important to realize that the natural history of this is reasonably long, and this is one of the main papers, Pound, in 1999. 8 years from PSA recurrence to clinical metastases, and 5 years from those metastases to death. Antonarakis, so this is a more recent BJUI article, and they looked at sort of the natural history as well at the Johns Hopkins Hospital. And these were 450 men with progression post-radical prostatectomy on those grounds, and they followed them up with 8 years. So in 8 years, 30% of those men developed metastases, and the median metastatic free survival was 10 years. So again, quite long periods from PSA recurrence to metastases and death. So what they found was that certain factors were associated with a higher risk of having metastases, and so that was a Gleason 7 or a Gleason 8 to 10, and the PSA doubling time was also important. But there was no difference for stage, margin. When looking at early versus late institution of androgen deprivation therapy for recurrence following prostatectomy, the Department of Defense Center for Prostate Disease Research published an observational study in 2004 for patients in the PSA era, and they looked at 1,352 men who had a PSA recurrence and had over 6 months. Early was defined as after recurrence but before clinical metastases, and late was no androgen deprivation until clinical metastases or follow-up. And so what they found was that for patients with a PSA of less than 5 and a Gleason score of 7 or more, PSA doubling time of 12 months, less than 12 months. So this is a higher risk group on the graph on the left-hand side here, that the early hormonal therapy institution improves the clinical metastatic free survival rate, and that was not seen in the overall cohort. So it was only the patients who had a Gleason 7 or more and a PSA doubling time of under. And this paper from the Mayo Clinic between 1990 and 1999 looked at the node-negative radical prostatectomy patients who received androgen deprivation therapy, and they looked at they defined adjuvant as within 90 days versus various PSA cutoff points. And what they found was that for the patients who had PSA adjuvant radiation therapy, it improved the biochemical recurrence-free rate and progression-free rate, but not the overall survival when it was given with PSA less than 0.4. But that was lost after a PSA greater than 4, so none of the other PSA values. Same group of people in a later study looked at T3B specifically, and 191 patients, and they were matched with other T3B patients who didn't receive androgen deprivation therapy, and they followed them for 10 years. And what they found was that patients who received adjuvant androgen deprivation therapy had benefits in biochemical recurrence rates, local recurrence rates, systemic disease, and cancer-specific survival, but not overall survival. There was a trend, but it was not significant. So all of these taken together, the European guidelines suggest a doubling time of less than 3 months, T3B, high Gleason scores, and a time to recurrence of less than 3 years, based on a study by Friedland, were the type of people that you would consider for androgen deprivation therapy following recurrence after a radical. So more recently, we're dealing with ultrasensitive PSAs, which can make it more confusing. And so this group from Korea found that when PSA was ultrasensitive PSA less than 0.001, then there was a 95.5% chance of recurrence-free survival. How is that helpful? Well, it's kind of still confusing. It's not, as we've seen, it's the doubling time that's potentially important, not necessarily the true value. And so how is this integrated into our... So I'm going to move on to node-positive patients now. So this is a 72-year-old man. He's got T2C disease. His PSA is 18 pre-op, and he has 2 out of 11 nodes positive. So this is, you see him in his first follow-up visit. And what PSA would prompt you to start androgen deprivation? So would anyone start it at any PSA level, undetectable? .05, anyone? Still. So the Messing trial is probably the most well-known in this scenario, and it was 1988 to 1983. And so they aimed to recruit 240 patients, but they didn't actually. They got 100, and they stopped recruiting because of PSA error, and they found it difficult to recruit. But the results are quite striking, and based on this for a long time, it was recommended that patients with node-positive disease should receive androgen deprivation. More recently, these are observational studies, to be fair, and using the SEER data, they found no difference in the overall survival in patients who received androgen deprivation therapy within 120 days for those who recurred versus those who did not. A similar observational study overall for patients who had recurrence post-radical prostatectomy. The overall survival was 60%, not bad, and the freedom from metastases 65%. So an important thing is that if they didn't recur within 5 years, then they've got 81% chance of recurrence-free. Risk factors that they found were Gleason score of over 7, and if there were more than 3 lymph nodes involved, which makes sense. So in practical terms, I think you just pretty much check the PSA and what happens after that is the way I see it. If you've got lots of positive nodes and high-risk disease, I think it's reasonable. What do you guys think? Yeah. So we're going to talk about intermittent. So an 80-year-old man treated with external beam radiation therapy 5 years ago. PSA pre-radiation was 17. Intermediate risk disease. PSA nadir 1.2. So his last year's PSA rose to 3.2. So what PSA? So this is 1 year on now from a PSA of 3.2. So what PSA would you consider starting deprivation? This patient doesn't want a salvage radical prostate. So anyone would start it at 4? Dr. So? Anyone would start it at 6? 7.5? 10. Okay. Okay. So I'm not going to spend a lot of time on this because we'll talk about it. It's sort of recurrence after primary treatment, which is a little bit similar to radical prostatectomy. But there was one in 2003, Panova and others looked at patients between 1989 to 1997 treated in Philadelphia with conformal technique, external beam radiation therapy. And their policy was to treat patients with recurrence if their PSA doubling time was less than 12 months, and observe men if their PSA doubling time was over 12 months. So they looked at 248 men who had PSA failure, and they looked at freedom from disease. And so what they found was that if their PSA doubling time was less than 12 months, they did significantly better with androgen deprivation therapy. They gathered these patients who had the observation because they refused androgen deprivation, because remember, it was their policy to give it. If their PSA doubling time was over 12 months and there was no difference in freedom from metastatic disease, and if their PSA nadir was above or below 1.5, that was significant, and if their PSA was between 7 and 10. This group looked, again, another retrospective comparative study in the USA, 1,200 men with T1 to 3 disease, and they found that early androgen deprivation therapy improved local failure rate, distant metastatic rate, cancer-specific death, and death due to any cause. So I'm not going to talk too much I'm going to move on to intermittent therapy because I think this is where the more interesting stuff is probably. So this perhaps isn't working quite as well as I'd hoped, but we'll try it. An 80-year-old man, he had a radical prostatectomy 3 years ago. His PSA at the diagnosis was 11. His T3B disease, Gleason 4+4=8. Margins clear, nodes negative. And his post-op PSA was 0.8. So he was started on intermittent androgen deprivation therapy. He had one cycle of 9 months and he's adhered down to 0.1. So 2 years following that now, what PSA would prompt you to restart androgen deprivation therapy? So when anyone go for 3.2? No, 5.2? 7? 12? You go 5? Okay. So Dr. Gleave in European Urology in 2014, intermittent androgen suppression has approached the balances, but then I'd probably ask you to say this while I'm here. Yeah. Benefits of early androgen deprivation therapy while reducing treatment-related side effects and expense. So the belief, if you think that early androgen deprivation therapy is of benefit, then you think intermittent androgen deprivation therapy might work, where it balances against the risks of androgen deprivation. And late 1980s, these young scientists thought that there might be a better way as well, rather than androgen deprivation therapy. And they looked at some animal models, and they found that with the LNCAP prostate tumor model, that intermittent androgen suppression prolonged the time to androgen-independent PSA gene regulation from 26 days to 77 days. So this is an animal model, it's promising, and I won't pretend to know much about what they did because I think some other people could probably talk about that better. Here, but around about the same time, Dr. Klotz was doing similar things, and he did a small pilot study with androgen deprivation therapy off and on using estrogen. And the patients would go on androgen deprivation therapy, then they would come off when their symptoms resolved, and they would go back on when the symptoms returned. And they found that in 9 out of 10 men who had normal erectile function prior were able to regain that. So it was promising. And then in 1995, from this department, a feasibility study, 47 locally advanced or metastatic patients, including 8 who progressed following radiation therapy. And there's a nice figure here showing that the PSA follows the testosterone nicely. And patients who are off cycle, they had an improved sense of well-being, recovery from libido, potency, who reported normal or near normal sexual function. More recently, and between then and now, there's been many studies looking at this, and this is a meta-analysis from JAMA Oncology 2015, which shows that basically intermittent androgen suppression versus continuous androgen suppression is similar in terms of outcome. What I should say is that in most studies they found improvement quality of life scores, but often not globally quality. So the PR7 trial was looking at non-metastatic hormone-sensitive patients who had previous radiation therapy, and it was a non-inferiority trial. Median survival was 9 and 9 years. So it was a trend for slightly better survival with continuous therapy, but it wasn't. So with this one, well, it's not, it's the same. In the SWOG trial, so I didn't get the to be recruited to this, I think they had to have the nadir +3, above 3. So in the SWOG trial, these were patients who were newly diagnosed with hormone-sensitive prostate, and this was a non-inferiority trial as well. And if the PSA dropped to below 4 on the intermittent on the androgen deprivation therapy, then they would be randomized to continuous run. So they had about 770 in both, and the follow-up was about 10 years. Yeah, that's right. Yeah. Oh, okay. Yeah. Yeah. Okay. And so they found that continuous versus intermittent radiation, androgen deprivation therapy was equivalent. But because of the way the trial was designed, they had pre the trial said that the non-inferiority limit was 1.2, and the confusing thing about this is that they can't say it's non-inferior, but they can't also say that it's inferior because it includes the 1.2, but it also includes the 1. So their results, they've concluded, is inconclusive, but I think common sense would tell you that it's the same. And they looked at quality of life, and basically at 3 and 9 months with the intermittent group, erectile function, libido, mental health, physical function were all better, but at 15 months it was only physical and superior. So this is just something I want to touch briefly on. So this is the theory going back to when intermittent androgen deprivation therapy was first started, was that if you take them off their castration, then it gives a chance to recover, and then therefore recover their apoptotic potential for the cells. And so some people have found that as the cycles of intermittent androgen suppression continue, it takes longer and longer for the testosterone to recover. So, but when you do intermittent androgen deprivation therapy, you base it on PSA and clinical grounds rather than testosterone. So the thought is that possibly we're starting androgen deprivation therapy before the patients had a chance to recover their testosterone. So this group has started looking at whether or not supraphysiological androgen levels cycling with castration may be of benefit. And there's been a pilot study in 2015. You might have more up to date about this. But right, yeah. Yeah, that's true. Yeah, that's true.
Concept. As prostate cancer progress, see their phenotype. We are really.
Yeah.
Still. We often. It's actually very different.
Yeah, yeah. Sure.
Very.
So overall, this is not a new topic, but I think as the management of prostate cancer evolves around deprivation therapy. And androgen deprivation therapy remain one of the cornerstones of treatment for advanced prostate cancer. I think it's important that this is not kind of completely ignored, especially as the life expectancy on these treatments keeps on extending. But prostate cancer is heterogeneous, treatment is heterogeneous, so there is no one size fits all. There's no real PSA cutoff. I was hoping to find exact trigger points, but most of them are just empirically done from trials, and this is a reasonable kind of trigger point, I guess. That could be debated. So what next? Batman, bipolar, androgen therapy, that's really CRPC, like we discussed. New modalities, how does this work with enzalutamide, abiraterone, and also in salvage radiation. So that's haere from me. Thanks.